Mania is a word we hear thrown around a lot, but it's often really misunderstood. So, in this explainer, we're going to get past all the stereotypes and dive straight into the clinical facts: what a manic episode really is, how it's identified, and importantly, how it's managed.
So let's just ask the big question right up front. What are the real signs of a manic episode? It's so easy to picture those dramatic portrayals we see in movies or on TV, but the clinical reality, it's way more specific. We're about to break down exactly what professionals are looking for.
Okay, first things first, we need to build a solid foundation. Before we can even think about spotting the signs, we have to get the clinical definition right. So, what exactly is a manic episode anyway? Now, the language here is super specific for a reason. This isn't just about feeling good. We're talking about a distinct period where the mood is elevated. That's that euphoric high or expansive, which means being overly social, maybe a little too friendly, with no boundaries, or it can even be intensely irritable. And that mood shift, along with a huge spike in energy, has to stick around for at least a full week.
And this right here is the absolute key. This is the crucial distinction. We're not talking about someone just having a great productive week. A true manic episode causes marked impairment. What that means is it's severe enough to seriously mess with a person's job, to damage their relationships, or cause major problems in their social life. This is the clinical line in the sand between a good mood and a genuine health crisis.
So, now that we have the definition locked down, how do clinicians actually go about identifying the specific symptoms? Well, they often use a really simple but powerful little memory trick to keep track of the 7 main signs. And here it is, dig fast. It might just look like a word, but this acronym is an incredibly handy way to remember the 7 core symptoms of a manic episode. So let's break down what each of these letters actually stands for. All right, let's get into it. D is for distractibility, where a person's attention is just pulled to everything and anything around them, making it impossible to focus. I stands for an increase in goal-directed activity, like suddenly starting 5 massive, ambitious projects at once. G is for grandiosity, this inflated, sometimes even delusional sense of self-importance. And F represents a flight of ideas, where thoughts are just racing so fast that speech can become a rapid-fire blur. Moving on, A is for an increase in activity, which can look like physical restlessness, pacing, just an inability to sit still. S is for a decreased need for sleep. And this is a really key detail. It's not insomnia. The person feels completely rested and buzzing with energy on just a few hours of sleep, or sometimes none at all. And finally, T is for talkative, which often comes out as pressured speech, where it feels like they physically can't stop talking. And this quote just hits the nail on the head. It's a huge misconception that mania is always about feeling happy or on top of the world. It can absolutely show up as extreme irritability and agitation. And when you combine that with poor judgment, well, that's what can lead to some really impulsive and risky behaviors, which is a major concern. Okay, so we know the what, but what about the why? I mean, where do manic episodes actually come from? Let's take a look at some of the common causes and triggers. This chart gives us a fantastic bird's eye view. As you can see, bipolar disorder is the biggest piece of the pie. It's the most common association. But, and this is super important, it is far from the only cause. Mania can also be brought on by substances, triggered by other medical problems, or even show up as a side effect of certain medications. That's why a really thorough medical workup is always essential. And to make that a little more concrete, here are just a few specific examples. Stimulant substances like cocaine or amphetamines, those are well-known triggers. But so are some prescribed medications, like certain antidepressants or even corticosteroids. And other medical issues, anything from an overactive thyroid to the after effects of a stroke, can also present with manic symptoms. So with all these potential symptoms and different causes floating around, how does a clinician actually make the call? Let's walk through the official diagnostic checklist they use. It's actually a very logical step-by-step process, all based on the DSM-5 criteria. So first, you confirm those core mood and energy changes have been going on for at least a week. Step 2, you count the symptoms. You need a specific number from that dig fast list we just went through. Step 3, you have to verify that it's causing that marked impairment we talked about earlier. And finally, step 4, you have to rule out other possible causes, like substance use or another medical condition. And what's that magic number from the dig fast list? It's 3. A clinician needs to confirm that at least 3 of those symptoms are present. Now, there's a little asterisk here. That number actually goes up to 4 if the person's mood is only irritable, without any of that euphoria. Okay, this brings us to our final and maybe the most important section, management. So once a diagnosis is made, what's the plan? How are manic episodes actually treated to help someone get back to a place of stability? Management is really a two-phase process, as you can see in this table. First, you have the acute phase. During an episode, the goal is immediate stabilization. Think of it as putting out the fire, using medications like mood stabilizers and antipsychotics. But the work doesn't stop there. The long-term goal is to prevent it from happening again, and that involves ongoing medication, combined with crucial support from psychotherapy. So let's look at the actual toolbox here. Mood stabilizers like lithium are often the cornerstone of treatment. Antipsychotics can help manage those acute symptoms, and for really severe cases, options like ECT might be considered. But look, medication is a huge piece of the puzzle for sure, but it's not the whole puzzle. Things like psychoeducation and psychotherapy are absolutely crucial for empowering the person and their family to understand the condition and build coping strategies for the long haul. So, we've covered the what, the why, and the how from a clinical point of view. But that kind of leaves us with a final, more human question, doesn't it? Understanding the checklist is vital, of course. But what does it really mean to offer effective, compassionate support to someone who's navigating this? That's a thought to carry with you.